It is my big pleasure to welcome everybody today at the episode 4 of the Hernia Basecamp Live. I would like to welcome my co-panelist, Professor Burwood from Ghent, and our presenter for today is somebody who doesn't need much introduction, but for the purpose of today he chose to be called the Master of Disaster, Andrew Beaux, and he's going to talk to us about how not to cause too many. So welcome and thank you.
Thank you very much for the opportunity to present this Basecamp session, Avoiding Disasters and Complications in Hernia Surgery. And I hope I'm not remembered as someone who's caused a lot of disasters or indeed complications, but I do hold to the view that surgeons who have not, who say they don't have any complications, have not done enough surgery. The more you do, the more you will see. These are my disclosures. There's not much there relevant to this talk, but I'm delighted to be a co-producer of Hernia Basecamp. Now, hernia accidents do happen, and they happen at the very top of the game. You know, Formula One racing are the best drivers in the world, but they smash their cars on a regular basis. But if we go back to this picture, I'm not an accident investigator, but you will get an impression from the amount of damage to that car that this car was probably in exceed of the speed limit, which was 13 miles an hour. So by observing the rules, observing what's going on round about us, we may minimise the risks of disasters and complications. And how to avoid them, I wish I knew. But I will give some broad brushstroke outlines around this. I will give some specific cases, and I hope there'll be something for everyone here. Now, I've had a privilege of having fellows work with me over the years, and many have said at the end of a difficult operation, you were lucky today. And to a certain extent, that's true, but it's a bit like exams. The more you know, the less luck you need about the questions. Now, I have a sweet tooth, and this is one of my favourite journals, the Confectioner's Journals. And in 1919, this was some advice given to some young people setting up in business, that they hoped that they would have luck, but you can make your own luck by hard work and the use of common sense. And part of this, in the UK, we set up Getting It Right First Time campaign. There's a lot of rights in this statement, but they are all important. And I'm going to focus more about doing it right and to a certain extent looking after them right. I'm going to say very little on prehabilitation. Informed consent is very important, and that's useful to know patient expectations, and I'll come back to that in my talk. And clearly perioperative decisions are also important, but what happens once you get into the OR and afterwards? And clearly we need to know how good we are, and following patients up isn't easy, particularly in the hernia world. There's not a lot of government support for this, but the European Hernia Society does have a registry if your country doesn't have its own, and would be fantastic to use it. Now, this is a complicated slide, but in the 17-18 period, and this is NHS England data, they did the total about 12,000 incisional large ventral hernia repairs. And these are the deciles, so the 12,000 patients divided into 10 groups. From the cheapest group, where the average cost of surgery was £1,700, to the most expensive group, where the average cost was £11,000. And when you look at the data, you can see that the cheapest group didn't stay in hospital very long, and the expensive group stayed in hospital a long time. It's easy to say, well, there are difficult hernias, there are difficult patients, there's patients with comorbidity, that's why they're more expensive. But within the limitations of HES data, we can see from this, from groups that are at risk, particularly smoking and obesity, unfortunately diabetes is not there, there was no real difference between the groups. If we try and identify features like recurrent admissions to hospital prior to the elective repair of the hernia as a risk group, there was no difference. Indeed, the expensive group were perhaps slightly less risky. So why did they cost so much money? Why did they spend so much time in hospital when they weren't more complicated? They were the same as the others. And perhaps then the surgeon as a risk factor is something to think about. Now, this is an old paper. It was written by my old boss, Sir David Carter. And there's some very important points in here. Surgery is not just about technical skills, so that clearly is important. There's other things that go on round about that. And surgeons don't work by ourselves, we work as a team, but clearly leadership as part of that team is also important. So a lot of my focus now is around us as surgeons and where we fit in to the picture. Again, going back, taking a step or two back, how do we reduce that need for luck? Well, let's focus on the patient. Decisions to operate, getting them fit. Oral health is an interesting one. There's very little evidence around oral hygiene related to mesh implants. It's very topical in orthopedics, but it's maybe something that we need to think about more as a source of infection. Skin bacteria, we focus on MRSA, but do we also consider other bacteria? And I'll come back to loss of domain. What operation? And if that operation is not achievable on the day, what's our plan B? What's our plan C? But moving more to the meat of the subject, what happens when you're in theatre and things start to go wrong? The Swiss cheese holes are lining up and we're heading towards a disaster. Well, hopefully experience will help us identify early on that something's happening and we can change course. Knowing what was discussed with the patient beforehand, what was their expectations, may allow us to adapt the surgery more easily rather than continuing in the course that was set. Colleagues are very important, our assistant is important, and please never be too big that you can't call for help from your colleagues. Whether that's senior or junior, often another pair of hands is all that is needed to help. A more recent concept is the stop timeout. It came from the LAPCO studies where clearly if there's bleeding, don't stop, control it. But once you've got control of the situation, the team should stop, even have a break, have a discussion as to how do we get out of this difficult situation and where we go on. Be prepared to adapt the plan. Because what happens in theatre sadly doesn't stay in the operating room. This is a very interesting paper to read, a large series from America. And when something goes wrong, these intraoperative adverse events, it affects every outcome measure for the patient, from morbidity, mortality, length of stay, cost, you name it. What happens in the OR doesn't stay in the OR. We love to blame our trainees. Again, another large American study where they divided senior surgeons into 4 quartiles based on their experience, and then the residents into junior or senior. And the bottom line is, when you finish your training, the first few years afterwards is when you're most dangerous at causing intraoperative adverse events. So beware of that in mind. It's not a new phenomenon. When you pass your driving test, that's when you're most likely to have an accident. When you start going alone, there's no one beside you in the seat, that's when you become dangerous. So beware of that. Involve colleagues and work towards it. But don't please blame your residents and involve them in the training. I mentioned loss of domain, and loss of domain is something I think which is poorly understood. We understand Tanaka, we understand the Sabah technique of measuring loss of domain, but those calculations would say that this caricature of an incisional hernia has 0 loss of domain. Clearly, there's a significant separation of the rectus muscles, but there's no calculable loss of domain. When we actually restore the abdominal cavity, particularly if the abdominal wall is not elastic, you can see that there's a significant reduction in the radius or the diameter of what we're left with. And that hatched area is the effective loss of domain. Remembering that the volume of a sphere, now the abdominal is not a sphere, but let's just talk about it somewhat abstract, is proportional to the radius to the power of 3. A small reduction in radius, huge reduction in volume. So this is a loss of domain that we don't measure, but is something that may have an impact to the patient. Hernia repair, I love this example. I think it came originally from Todd Henneford. Hernia repair, particularly for large hernias, it's kind of get that sleeping bag into the sac. Now you can make the sleeping bag smaller or you can make the sac bigger. The only really effective way of making the sac smaller is weight loss. Bowel prep is not something that is encouraged. And clearly, organ resection intraoperatively changes a clean operation to a clean contaminated operation at least, which will increase your risk of complications and indeed disasters. And then obviously making the sac bigger, I'm not going to go into any of these, but there are things that you can do, particularly intraoperatively, that will help you improve the situation, with bridging there as a last resort. But it's not just getting the muscles together. The only bit that the patient sees is the skin. So how do you get good skin cover? How do you minimize dead space for seromas? These are options. Do we use glue? Do we use negative pressure wound therapy, increasing evidence in incisional hernia? And the law of diminishing returns. The Sky Racing team were famous for that in cycling. They made small changes so that they would win. There's not a lot of evidence that care bundles work, but again, think about that. Mesh infection, it's an absolute disaster, and I'll show you some disasters shortly. But can we minimize infection? Well, get rid of dead space, stop pooling of fluids. Does the mesh type matter? And that's open for debate. Don't leave it lying around. It is a foreign implant. Open it just before use. Change gloves, perhaps change instruments. Don't let it touch the skin. Antibiotics, care bundles. There's a lot of work to be done to minimize a mesh infection. Which mesh? You read the literature and you end up with a sign like this and you think, help, what do I do? We need to be more proactive. We need to come up with an easier algorithms that are easy to use. But again, personal experience will influence those. But it is important that we go for small gains with a chance of minimizing mesh infection, because when it does happen, it's a bit of a disaster. I don't want to spend too much time talking about treatment, but the fingers crossed, going for luck, wound dressings, I suspect, will rarely work. So an exposure and vacuuming or removing it is the way forward. And you saw those little holes, but when you open it up, often it's the tip of the iceberg. There's a lot more going underneath. Add in obesity, add in diabetes, add in frailty, and you've probably given this patient a life sentence of misery because they're not fit to deal with it. Again, typical type incision for transplants or cancer resection, often non-curative, and the patient's going to end up like this. So there are a lot of issues that go on around mesh infection. They are a disaster. I don't have all the answers on how to stop them happening, but I've given you some suggestions. And just doing it laparoscopically doesn't stop mesh infection. This is one of my own IPOMs. Small incision through the umbilicus, and you can see the mesh just floats out with it. It's never stuck in. So even laparoscopic won't stop it happening. And clearly a mesh erosion, try and keep mesh out of the abdominal cavity and be careful about mesh selection. And even a couple of years down the line, you think it's all healed up and you're okay. Here's a little sinus you can see on the blue arrow on the CT scan. You think, oh, it's just superficial. But sadly, the CT shows that tracking down to a huge collection sitting around the mesh. So even late infection appearing years after the event can be an issue. Moving on to a similar but unrelated topic, also what I call the missed bowel injury. Now, hopefully you won't see many of these. I've had quite a large medical legal practice, so I've been involved with a lot of these cases. Unfortunately, none of them were my own, but this is something that I have now called a missed bowel injury. And I think it's missed partly through ignorance. I'm going to run through this case very briefly. There's nothing particularly unusual about her. She had Hartmann's, she's had a laparoscopic reversal, she's now developed an incisional hernia, and so the plan is to do a laparoscopic repair. At the time of surgery, there's a recognized small bowel injury, there's a serosal injury, and these are repaired. She does well overnight, but at the start of the next post-operative day, she's becoming more sore. She's mild temperature, heart rate's creeping up a bit, but she's got significant abdominal wall bruising, and her oxygen saturations are falling a little bit. So the working diagnosis of the team is she probably has a bit of atelectasis, partly for the temperature, and maybe there's an early infected hematoma. To cut a long story short, on post-operative day 4, she goes back to theatre and has 4-quadrant peritonitis from a missed small bowel injury. She obviously has a typical stay afterwards. But when you go through her medical record, look at that. She had 28 medical consults between the first operation and the second operation 4 days later, of varying specialties and of varying experience. And none of them thought, well, we had one bowel injury, we've repaired it, has that broken down, or indeed another one? And it was put off. And I'd put it, and she successfully got an out-of-court settlement for almost £500,000. And that's what she got, and obviously the costs of the process were probably several times that, a very expensive thing. So the missed bowel injury, I would put it to you that a patient post-lap hernia repair, doesn't matter where it is, TEP, TAP, IPOM, ETEP, is not able to go home within 36 hours, pain's getting worse, or clinical observations are deteriorating. There is a surgical problem until proven otherwise. You can do a CT. There'll often be some free gas. Was that left over from the operation? Is it because of perforation? And the simplest thing is to put them back to sleep and stick a camera in. If all looks good, wake them back up and you label them as a bit of a wimp when it comes to pain. But if you see a bit of bile, more fluid than you expected, you will save a very complicated recovery for that patient. Now, there's no doubt that laparoscopic surgery, and I don't want to come across as bashing laparoscopic surgery, does reduce your risk of complications in general. Now, this is an old study, so the laparoscopic group 1 and 3 had a complication. In the open group, 1 and 2 had a complication. But look at the frame shift. The purple bars are the laparoscopic group. More class 3B, that's complications needing an operation to fix. More class 4As, that's an operation, that's a complication that's potentially life-threatening. So be careful, ladies and gentlemen. Minimally invasive surgery, when it goes wrong, and this is my preferred method of a cut down, can sometimes end up with maximally invasive surgery. So bear that in mind. The deteriorating patient post-lap repair, a surgical problem until proven otherwise. Yeah, I'm getting close to the end now. Decisions for surgery. Going back to it, what does the patient want? What is their expectation? Also, what can you do? It's not what you've just seen on a YouTube video or indeed on Hernia Basecamp, but you should also tie in what you can do. Pathways, I think, are something that are useful. And if you have an abdominal wall pathway where patients can come through, be pre-optimized, both medically, weight, hernia-wise, is important. But remember, what happens in the OR impacts outcomes. It doesn't stay there. It travels with the patient sometimes for the rest of their life. And active post-operative care is part of that. What can you do? Well, clearly knowledge is a good place to start, and I would encourage all our listeners to be a member of their local hernia society. For those in Europe, be members of the European Hernia Society, and for those further afield, join your local international group. Do go to conferences. Lots of surgeons will turn up there and honestly bare their breasts in a sense of their complications. First of all, how to avoid doing them, and secondly, if you do end up in a problem, how to deal with it. Hernia Basecamp, as part of the driver of our work, is to improve knowledge. Be involved. Lots of things happen, from working groups to guideline writing. Yes, you may know nothing about guideline methodology, but try and get onto a group and learn. I'm a bit old, as you can see, a lot of grey hairs. I'm not really into social media, but I've become into Twitter, Facebook groups because of the knowledge that you can get from this. I'm not interested in posting about my summer holidays, and I'm sure you're not interested in seeing them either. But there's a lot about there that you can learn. And for those in Europe, indeed further afield, UMS now recognises abdominal wall surgery as a separate subspecialty, which you may wish to sit the exam and join that. Support is very important. I've already mentioned never be too big to call for help in theatre, but enjoy the ability to travel the world, and that's one of the things that I've enjoyed, is seeing surgeons elsewhere. This is one of my favourite work photographs. You recognise me on the side. The gentleman on the opposite side is Maciej Pawlak. He was my fellow for 2 years. When he finished, he got a job in England, and he's now back in Scotland, and we do a lot of discussions around cases and pathways. And in the middle is Pavlo from Ukraine, who came on an EHS travelling fellowship, and we continue to interact and work together. So support and network. Do travel, do visit people, and you will end up with a group that you can work with. I mentioned luck, and I hope that you continue to be lucky in surgery, but this is a primary ventral hernia. It's a simple primary ventral hernia. But yet it's destroying this lady's life, her ability to exercise, do things, and yet with a bit of luck, you can transform their lives. It's a fantastic specialty to be in. There will be complications, there will be disasters along the way, but try and stay strong, be knowledgeable, and all the very best. Thank you.
Thank you, Andrew. Thank you, Andrew. A very nice overview of all the things that can go wrong in hernia surgery. I think maybe it's interesting to have a little bit of an overlook for trainees, for residents, for young surgeons. If we state that being prepared, having the knowledge is so important, of course we might question no hernia might just be not just an hernia. It might be complicated, more complicated, and so on. And what is your opinion in terms of taking the next step for a young surgeon, or even at the final stage of the training, to say, okay, I can deal with this, I feel secure? Is that just a personal decision, or do you think there are certain steps of being ready for a surgeon procedure in hernia surgery?
Yeah, I don't want to be too prescriptive and say you have to have done these courses, you have to have these qualifications and what have you. And surgery is a learning curve. And, you and I have been around for a while, and I would say I'm still learning. I still enjoy traveling. I still go and sit in conferences, and I come away with snippets of information which I take home and use in my practice. So it is a learning curve. Until recently, we've not had good training pathways in abdominal wall repair. The cancer surgery, yes. So I guess it's a matter of if you're fortunate to work in an area that does a lot of abdominal wall surgery, then you're going to be trained. For those that don't, you're going to have to do it yourself. And one of the comments I do make, it's very easy to say, well, this operation is a good indication for this hernia, but if I've never done it before, I'm not a great fan of practicing on patients.
No, sure, I fully agree. Second, maybe before I leave the questions also to Barbara, of course, is you touched upon a lot of specific issues that we can come across when treating those patients. And for example, I heard you talk about the wound care bundle. I think wound morbidity is still one of the most feared complications, including mesh infection after hernia repair. How do you feel, you shortly mentioned it, but how do you feel about using the closed negative pressure therapy in every hernia patients, except the inguinal maybe, or this very small primary ventral, but in general, is that already something that has been introduced in your practice every day, or is it just...
It's something that we're doing more. There's no doubt the UK is probably no different than many other centres in that healthcare budgets are compartmentalised. So if I use something expensive in theatre, even though it's cheaper for the community, money doesn't flow. So I have to do a very complicated business case for introduction. And a high quality closed wound negative wound pressure therapy is 100, maybe 1,000 times more expensive than a simple dressing. So I think it's not something for everyone. It's also not always easy to place it where you want to place it. So wounds that are affected wounds in the groin, close to stomas, you need a certain overlap, and it does become more complicated to get that seal. It is possible, but you have to understand the tricks of the process. So I don't think it's for everyone, but I think it will become more of a standard of care as the years go by. I don't fully understand how it works, but certainly in the obese, for the diabetics, there's now not in hernia surgery randomized controlled trial information, but certainly anecdotal data from large series suggesting that it does reduce wound events.
Yes, I think also from the literature that the SSI rate will probably go down in your practice if you use it in selected cases versus the surgical site occurrences that might just be postponed a little bit but not really prevented. So I fully agree with you. A last short question, maybe because it intrigued me, the mesh infection, which is of course, like you mentioned, a disaster for everybody doing hernia surgery. In terms of mesh choice, how is your current practice in evaluation? I need biosynthetic mesh versus a synthetic, or even maybe still relying on biological mesh. How do you evaluate those cases?
Yeah, I work in a poor country. Scotland is a poor country. And I think that a large pore mesh, synthetic mesh, will deal with most situations. Obviously, as you get a tertiary referral practice, you get patients coming to you with abdominal repair who have sepsis ongoing at that time. You're going to have to think about different things. And it's also what the patient wants. A patient who's had a mesh that's got infected, they're very frightened to have another mesh. So while the partially absorbable meshes, I think the evidence is still not fully out there as to whether they work long term. I wonder if short term it's easier to say to the patient, well, I'll put something in, and if something really badly goes wrong in terms of infection, we just have to sit it out till this mesh disappears and then the infection will settle down. And I have very little experience with biological meshes. And I think while they came out with initial enthusiasm, I think the world is reducing their use. America was a very common user of biological mesh and yet the number of pieces they use is decreasing. So I'm not to say that they've come and gone, and to say that we have the best mesh now. 20 years from now, there'll be different meshes out there. So we mustn't limit science. And I had the privilege of collaborating with Barbara on a liquid mesh, something you could pour in, which is really spooky but interesting for the future.
Okay, I'm sure Barbara has questions for you as well. Thank you.
That's what I'm worried about.
No, you don't have to be.
I feel like I'm an examination now.
No.
This is supposed to be an educational promotion. I'm feeling interrogated.
It's just like you've opened a whole can of worms with your talk, and you were talking about all the disasters. Missed bowel injury, which is probably one of the worst things after some severe hemorrhage, which you have to deal in intraoperatively, that we can think about, but also mesh infection. It's a huge disaster for the patient. But in the second part of your talk, it has all come to sort of self-awareness, humbleness, maybe empathy, trying to feel with the patient. It almost, I know we live in the no-blame culture and we should never point fingers, but it almost seems like from your talk that a lot of the complications are really our fault, either because we didn't think things through enough. We considered a hernia just a hernia, an easy operation, and we didn't do the right procedure, or we have done something which we either didn't train enough for, or we simply did it wrongly because we have overlooked something. Maybe we were rushing or thinking about something else. Do you think a surgical community is ready to accept these thoughts and change the process of how we train and how we treat, how the seriousness we apply to all of our decision making outside of the cancer care? Because in cancer surgery, this is all there. Transplant surgery, this is all there. With hernias, we're still lacking this approach.
Yeah, I think, there's no quick answer to that, Barbara, so shut me up if I talk too long. But, there are some very good social media channels where people present their cases and ask for opinion. Now, perhaps they're presenting those cases because they want to say, look at me, I've got huge hernia cases, but perhaps they're presenting them because they generally don't know what to do. Now, if I had a patient, say, for example, with a pancreatic cancer, I wouldn't post it and say, here's a CT scan of pancreatic cancer, what operation would I do? So Frederick gets back to me and says, this patient needs a Whipples. I say, thanks very much, Frederick. Give me 5 lines how to do a Whipples. But I see that every day in hernia surgery, and that's just wrong. That's just plain wrong. And clearly there's the knowledge around that. But also there's the an interesting area, as I mentioned, the surgeon as a risk factor. But there's some recent studies that, for example, identified that morbidity of surgery is higher on the surgeon's birthday. We know that events happening, whether it's marital upset, whether it's loss of a loved one, whether it's child in trouble at school, they take up part of our brain's thinking ability, and therefore reduces our brain, the RAM we have, to function in theatre. And yet surgeons have this sort of view that, we keep going no matter what's happening, and we don't have the ability to say, actually, my life is chaotic. I need to not do this operation. And I'm not saying that maybe that we should do that for a trivial thing. The tree fell over in the garden, so I'm going to have the day off. But we have to be aware of our mental processes and make sure that we try and be in the best shape, that's sober, hopefully having a good sleep, and all these things that allow us to do the best for our patients. Now, I'm no saint. I've done all sorts of things that I wish I hadn't done. In retrospect, I was lucky. But having been around for a while, I'm aware of the importance of the surgeon. Easy to blame the patient, and I love blaming the patient. When their hernia comes back, they did too much too soon, even though I've told them they can do whatever they want as soon as they want. And I tell that, you can do whatever you want. And when your hernia comes back, it's not because you did too much too soon, but I will blame you for doing too much too soon, because it's not my fault.
I'd like to challenge you a little bit because you just said something which, I'm a little bit of a diversity warrior, and you've said something that suggested that if we have a child in trouble or we're slightly emotional, we have a worse result. And I think it's something which we discuss all the time, that women tend to be a lot more emotional than men, but women have better operating results than men in the few studies that were published, and there are definitely no studies showing that they would have worse results. So maybe men are very emotional surgeons.
That's an interesting Knight's move. So we've gone from some preliminary data to, but I agree with you. It is possible the results are generally better for women. There was a big study recently, I think was it Canada, on general surgery that showed even mortality in benign elective surgery was less. So there clearly are differences. I know in some countries that's a real difficult study to believe and to conceptualize. Perhaps the same emotions happen to women and men, but they deal with it in a better way. I don't know. We're now ahead of ourselves. But you're right, the surgeon as a risk factor is quite important. And the traditional view of the strong male person as the ideal stereotype of a surgeon is being challenged. And unfortunately, that concept is not standing up to the challenge.
I keep thinking about Todd Henneford and all his talks about the surgical ego. And I sort of wonder if there is anything we can do. How can we build this into the general surgical education? How can we incorporate this as the basic principle of surgery, to leave your ego outside of the operating room and be there just for the surgery and for the patient that you're gonna operate on?
Again, there are a variety of courses now which help surgeons develop the other skills. We focus on technical skills. We judge surgeons by how quick they are, by how good they are, and whether their local medical colleagues would go to them for an operation. Are you the doctor's surgeon in a sense? And yet speed is very important. But there's clearly more to it than that. One of the interesting things that was developed in Edinburgh was NOTS, the Non-Operative Technical Surgical Skills course. For many good surgeons, they have innate concept about these things, knowing their strengths, their weaknesses, being able to communicate. When you start to have blood loss in theatre, you immediately announce that. So the anaesthetist stops playing on their computer, starts to pay a bit more attention, starts to look at what's coming into the suction, maybe ask for a level 1 warmer. The theatre team are now getting some O-negative blood out of the fridge and bringing it at the theatre in case it's required, rather than the anaesthetist noticing it because the surgeon is kept quiet and when the blood pressure falls. So there are a lot of things that we can learn if we're not good at that to improve. And communication is very important. But I'm old. I came from my father was a surgeon, and I came from the same mold. He was autocratic, and there was his way and the wrong way. And I grew up with that, and I realized that's not correct. And I've tried to improve that. I've tried to be encourage humility, never be too big to call for help.
And are you aware of any other courses which would be, or does the Edinburgh Medical University offer any counseling services or how do you modify your own feelings during the operation? It's not only about communication, it's also about handling yourself, how to stay calm. You mentioned not to blame the resident. How do you stop yourself from getting angry with your resident if they are operating slower than you would like to? Because I believe this is also a very common source of mistakes when somebody is pushed to do something which is beyond their ability. Is there anything like that?
I'm probably guilty of all those things, but I suspect I get most cross in theatre or most angry in theatre at myself. I get cross at my incompetence when I've done something that I shouldn't do. I guess avoiding bleeding is much better than getting into a bleeding situation and dealing with it, and then blood obscures the planes. So I get cross at myself for that. You do rely a little bit on your team to feed back to you. Unfortunately, a lot won't, but if you can get an older a theatre nurse who's seen it all before and is prepared to take you aside, and if they do, listen to them. It's hard. There might be some tears involved, but listen to them and go away and have a look at yourself. But unfortunately, the surgical ego is a big problem.
Frederick, how do you deal with these situations in Belgium? Is that part of the training, the self-awareness and how to modify your own emotions?
I'm not sure it's so much part of the training. Of course, I think the focus is going away a little bit from only technical skills to, let's say, all the other skills we need in treating patients. On the other hand, it's of course difficult to build it in your training program. I think it's important to let the trainees understand that it is an aspect that we cannot ignore and that is very important in treating with patients overall. And of course, as you mentioned, I mean, it's changing over time, and I think it's important that it changed already a little bit, but it will go slowly, and I think system by system, country by country, even department or hospital by hospital, it might be at a different speed. But I certainly think that the younger surgeons are already less bossy in a number of times than maybe previous colleagues like Andrew and my generation. On the other hand, sometimes we have to realize, and at least that's a little bit also my personal input, that depending whether it's hernia surgery, oncological surgery, or transplant surgery, severe, less severe, we are in a quite stressed environment. And we need also to deal with this stress. And if you only are in stress when the trouble has started, it's maybe not the best way to deal with it. So you should also be trained in a certain environment of stress. And I don't think it should be only empathy, and you don't blame yourself because you cannot help it, and you should learn. And I mean, there should be a balance between those things, at least. That's what my personal opinion is.
So let me ask both of you the same question. So you did an operation, you caused maybe a life-threatening complication, the patient survived or maybe didn't survive. How do you feel when you go to the theater next time? What do you think should be the right approach? Or maybe you've caused the same complications several times in a row. Maybe in HPB and transplant, liver transplant surgery, complications are more common and more expected than with abdominal wall repair. But how do you handle situations like this? Are you scared when you go back to the theater? Are you nervous? Do your hands shake? Or do you just depersonalize?
If I can start, I think in my mind a good way to cope with these complications is that if you know for yourself that you thought about it beforehand and still something happens, it should only happen once. I mean, you should take extra care the next time and the next time and the next time just to prevent this horrible thing to happen a second time. Of course, you can never be sure. There will always be this risk, but your real disaster should be in the back of your mind all the time. And of course, everybody hopes, I think Andrew will agree, that you don't deal with every complication and every disaster before preventing them during your career. But on the other hand, I mean, you should be self-critical. You should keep your disasters in the back of your head and in that way improve and go slow the next time to prevent at least the ones you had in your past. That would be my opinion.
I think that's true. I say these patients haunt you. Now, I can probably give you the names of all the disasters, the real disasters, the people that nearly died as a result, indeed the ones that did die. Fortunately, they're relatively small, so I don't have a list of long names, but they haunt me. And they're in the back of my head every time I start an operation of a similar ilk. And you learn from it. And you know, you probably have experience from bile duct injuries. There's a fair bit of you know, when you look at the videos, they just got lost. You know, there was no stop, there was no timeout. The camera angle was slightly wrong because that's a resident's fault. Well, if the camera angle's wrong, sort that out. Don't just continue. So these are often little things that add up, and then you get the complication through the holes. But yes, they haunt you. But you do learn, and I hope that's a difference. All surgeons should learn from their mistakes and from their colleagues' mistakes as well. That's what M&M meetings should be about, is to share what went wrong, how you think it went wrong, and you can stop it happening again.
I think that also shows how important registries are, because they really show the global impact of these mistakes and of everything we cause. And unfortunately for cancer care, we have lots of registries and we have a very thorough follow-ups. For hernias, it's a little bit voluntary for now, and we don't really know what is the impact of our work, and if we have done good job or bad job. We see the missed bowel injuries, but we don't see all the recurrences. So maybe
Yeah, I think that's very true, but it's not just the registry of the operation, it's the long term. So there's a general feeling now that intra-abdominal mesh does store up some problems for the future. The bigger it is, the less likely that patient will be fit for a laparoscopic operation in the future. So if you put a large mesh in the abdominal cavity in someone in their 30s, who may still have pancreatic cancer, colorectal cancer, common cancers in Europe, you won't be able to do it laparoscopically. You might not even be able to take their gallbladder out laparoscopically. We don't collect that data very well. RCTs are very good at telling us if a treatment works or not, either against placebo or best available care. But registries tell us what effective treatment works in what group, because most RCTs will try and keep the group homogeneous, and then the generalizability comes from that real-world data, which is effectively registries, whether that's insurance data or whether it's specific operation related, and that allows us to work out who should have what treatments. And we're not good at doing that. And it's just a hernia. We talked about training at the start of the discussion. We're not really focused on that. Why do we collect hernia data? What are our outcomes in wound infection? Do you know yours? You have some idea, but it's a number made up in your head, accepting that 98% of facts are made up on the spot. But we are very poor at collecting our data.
This is something which it's a little bit unfair to our industry partners as well, a little bit, because there's quite a few angry patients out there who have experienced the complication, and very rarely the surgeon says, "I'm sorry, I made a mistake," or "something went wrong." It's quite a common experience of many of at least the patients that we speak to. They say either they were blamed or a specific product was blamed. I hear it all the time, the stapler failed. But was the stapler actually used the correct way? Was the right pressure applied? Or, why do some surgeons have stapler failures all the time, while in some hands it works perfectly? I know that in the EHS we have improved the cooperation with the patients, and we try to explain it a little bit better to them. But when you mentioned the GIRFT concept, our patient representative, Jackie, she told me once, she said, and the surgeons now, they have this getting it right the first time department. How many goes do they want to have at me? So maybe our communication towards the patients should improve as well on this front. What do you think?
I think that's true. It's part to honesty, and it goes round and round in circles. So I see a number of patients, for example, who have been told they shouldn't have an operation because it'll kill them. But that's if a surgeon doesn't want to do something, you say, "Oh, it's going to be really risky. I wouldn't have it done," even though it's impacting their quality of life. Then I have people who I see. Unfortunately, I'm a relatively expensive surgeon, so they'll say, "Oh, can't afford that." They go somewhere else, they get a problem, they come back and now want their infected mesh and their hernia repaired. And I say, well, I can't do all of those things. I can start but systematically taking that infected mesh out, see how things go, and then we have a second go. That's not to say that you have a perfect operation if you come to me. But what you talked about, staple failure, is interesting. I've used thousands of staplers, and I've never had a staple line failure except once. And that's when I tried to staple across an orogastric tube. And of course, the staple failed. And then the gastric sleeve, they got a leak. Now I could blame the stapler, right? It failed, but I was trying to cut across the orogastric tube. I've never seen it fail. Now that's not to say they don't happen, but they don't happen with the regularity that many people say they do. We have to be honest as surgeons, and we have to focus, look at what we do. Knowledge is vital, support is vital, and work within our limits. And if we're not good enough to do the surgery, refer it to someone else or learn. And that's one of the great things, for example, of Hernia Basecamp. You can see from those lectures who's doing the fancy surgery. Join the EHS, get a travel grant, go and see them. And you're never too old to learn.
Maybe before we slowly move to an end of the discussion, of course, we talked a lot about the patient as a victim. We also said just a few minutes ago that as a surgeon, we take our disasters with us, and it will probably help us to improve, but it's also a burden. What is your opinion about the current situation with the surgeon as the so-called second victim? Is that given enough priority? Because I think a lot of surgeons have to deal with these burdens that they carry.
I think it hasn't been. Again, I can only speak for the environment that I work in, but you would maybe have, after a disaster, you would have an initial response. We have a rule, for example, if someone dies in theatre with an elective operation, that surgeon goes home and doesn't continue the operating list. And that's for obvious reasons. But that's a very extreme example. Very few people die in theatre from elective surgery. And there may be a few phone calls in the first day or two, and then it goes silent. And I think recovering from major complications is quite hard for a surgeon. And I think they are the second victim. There are groups looking at that at the EHS conference in Manchester 2 years ago. Hathan from America came and spoke about that. They're doing a lot of work that if when there is a major disaster, major complication, there is a pathway that the surgeon, in addition to the patient, looking after the patient and the patient's relative, the surgeon gets slotted into that too. And most surgeons that I know, not all, so this is a generalization, are not good at asking for help. It's part of that surgical ego. To ask for help is a weakness, and to expose weakness is something that the surgical ego doesn't want to do. And therefore, relying on a system that's passive, so you have to ask for help, often doesn't work. You have to not force the help on someone, but bring it in. And it's something I didn't really think too much about, but as you go on and you see more and more complications, and you see the effect on some of my colleagues, and for some colleagues or surgeons that I've known, a major disaster has been a career ending for them. So mentally, they've said, we can't cope with this anymore, and we're going to stop. They may not have stopped career in medicine, but they've stopped operating. So as I mentioned earlier, they do haunt you. It's in the back of your head, it's in the back of my head. Yeah, and I think the surgeon as a second victim is a real phenomenon, and we have to work harder to support that. I think it's as a changing practice. We talk a lot about training times. They seem to be shortening. Perhaps people are coming out less generally trained, so that if you do something outside your little area, you're not quite sure what to do. So working as teams, co-consultant or co-attendings working together. But again, and I don't know how many times I've said it in this webinar, but never be too big to ask for help. I think that's that, because at the end of the day, the only one who really suffers is the patient.
Okay, I think this is a very nice last statement to take with us for our further future. I would like to thank you, of course, Andrew,
Sure.
and also my co-moderator, Barbara. I think we learned a lot about disasters, complications, how to prevent, how to be self-critical, how to take the baggage or the extra deals we learn with us to the future. And I would like to thank all of you for your attention with this nice session of Basecamp. Thank you.
Watch the replay of that webinar. It was a depressing talk, wasn't it?
Yeah, it was a little bit like a dark
I need cheering up. So let's what can we do to cheer ourselves up?
I have a question for you. Where is the line for a surgeon between being too critical of themselves and being too uncritical? Where do you draw the line? You know, how many mistakes do you accept and you say it's just the fate is the learning curve? Can we ever blame learning curve for a mistake we have made? Or is it always something that we should carry with ourselves?
Where's the line?
I always think back to the sort of adrenaline curve, and I suspect most interactions follow that curve. So fear is a useful thing. So, for athletes, for whatever we do, as the adrenaline increases, our performance improves, our coordination, our thought processes, and whatever you improve. But there comes a point where that reaches the zenith, and then further increases in adrenaline make you start to perform badly. And it's trying to know where is your sweet spot of adrenaline, in a sense, where's your sweet spot of the fear of the surgery, which allows you to perform better. And when are you going actually over the edge and now starting to get the levels of adrenaline or whatever thought processes that make you perform less well. And for people, different people, that will vary a bit.
No, it's actually not what I meant. I meant, imagine you're a young surgeon, you're a trainee, you're operating, and the person who is operating with you, who's more experienced with you, who's helping you, who's holding the camera, you make a mistake. And what makes you think you should just live with that mistake and let it go? When is the line when you say, oh, it was the other person's fault? I know you were talking about when you're already older and more experienced, but if you're, in a young man's position, when do you take the responsibility? At what point?
I guess it depends what you were doing in the operation.
The line.
I see a number of operations where, and I'm guilty of this too, where the person operating is operating with me telling them what to do. So they haven't got that flow to the surgery because they're waiting for my instruction for the next step. And performing an operation with someone else doing it is can be unsettling for them too. And I've become more aware of that as we go on. I do think the sort of psychology of learning is getting better. Traditionally, surgeons would shout at you when you made a mistake, and then you'd go home, possibly in tears, and get back the next day and come back to work. And I think there are a lot of structured ways that you can discuss what went well in theatre and what went wrong in theatre, and what do you think were the reasons why it went wrong? Was it lack of knowledge of anatomy? Was it lack of good handling of the tissues? Was it just a bad luck situation? And you try and work out and say, well, avoidance is better than coping with a problem. How are we going to stop it happening again? So I think empathetic discussion after the event is very useful.
Yeah, but it still doesn't answer my question.
Ask the question again. Well, there's some people, I think you're saying that I think there's some people who are hard to teach because but that's not necessarily true for surgery. It's about anything, that it's always the other things or other person's problem. Whether you're baking a cake, well, it was the wrong flour, or the oven temperature was wrong. But those are things that we can actually control. What flour we buy, what temperature we set the oven at, are things that are in our control. But we can be good at blaming other things. I think it is important to think about the operations that went well and why they went well, and also to think about your operations that didn't go so well and why they didn't go so well. And that's true right across surgery. It may be a consultation with a patient, you misjudged them, the tone of the consultation went badly, and you reflect on the ones that went well and the ones that didn't go so well. And as I said in the webinar, I don't have all the answers either. I see myself in my late 50s as still very much still learning.
I have also a little correction for you. So if you operate or if you are under stress, your adrenaline goes up, you don't perform better. You can run faster for a while if you are running away from a tiger or something, but for surgery, it doesn't have any benefit. You get a tunnel vision and your intellect actually goes down. So if anything, you should never be stressed when you're operating. And I think a thorough learning and preparing yourself for the operation, it should never be a thrill for you. It's not a game. It's not a
Yeah, it's
computer
not.
game.
Yeah,
It's not, you know,
understand what you're
shouldn't be
saying,
stressful for the surgeon.
but I think most people will find that there's a degree of stress with surgery, and I think that is important. When you get familiarized with an operation and you think that you have cracked that operation and you're completely laid back going into theater going, I've done all this so many times, nothing could go wrong now, that's a dangerous time as well. So always be a little bit
Yeah, I don't mean
about
turning
surgery.
into a surfer
But if
dude,
you're a
but
little bit
just taking it
frightened,
seriously.
yeah, but if you're a little bit frightened about surgery, your adrenaline will go up. And it goes up. It does improve your hand-eye coordination, that kind of thing. It does improve speed of thought processing, but there's clearly a situation when you're terrified and the adrenaline is very high that your performance will go down. I'm convinced of it.
Do we have any questions from anybody? I'm actually not sure we do. I think people are too depressed.
Well, we did get a little bit depressed, but I think the take-home messages are you should look at our complications, learn from them, learn from others. I think surgery is a great career to be in. I'm slightly concerned that I'm the wrong gender and I shouldn't have bothered, but our future generation will have be women, and I appreciate that. And it is a great job to be in, and the ability to travel, whether it be to conferences, whether it's to watch other people operate, or encourage others to come and operate in your center. It's such a privilege to be part of that group of what we've now termed #Hernia Friends, to use a social media term, that I would encourage everyone to make use of the opportunities. I traveled quite a lot initially at my own expense, but there are EHS grants and there are other opportunities as well. So it's a lifelong of learning. It's a great job to be in. I know hernia surgeons are the lowest of the low in terms of the coolness and awesomeness factor, but it's been something that I've thoroughly enjoyed, and I haven't hung up my guns yet.
So we have a question. What role do you think surgeon and medical provider communication to caregivers play in outcomes and preventing missed complications?
Yeah, now that's a very interesting one. So in Scotland, where I've done most of my practice, working for the government, we aren't paid for what we do. My hospital gets paid a sum of money and it has to look after the local population, and for the tertiary referral stuff, and I make decisions about the patient on an individual basis, accepting that in a country with limited resources, which is true right across the world, what I spend on one patient, I can't spend on another patient. The difficulty then comes when you go to patients that might have private insurance or patients that are paying for the surgery themselves. And then it becomes more of a menu. Even a simple umbilical hernia could be open suture, open preperitoneal mesh, could have an ETEP, could have an IPOM, and they will have different costs attached to them, different risks, different benefits. And obviously we need to discuss those with the patients, but sometimes the patient will be making a decision on cost. What can they afford? And then insurance companies tend to be a little bit slow in the process. So for example, most insurance companies won't recognize Botox, progressive pneumoperitoneum, or they pay poor rates where to earn an honest living, you're better off doing a whole lot of suture repairs that recur every year and you get paid every year, rather than doing one operation properly, which hopefully will last the patient for their lifetime. So we haven't got healthcare completely sorted out. There are lots of factors that make decisions both between the surgeon and the patient interface. And then going back to something I did say is, what can you do? Yes, there might be an algorithm, particularly as we get more AI coming in, that says this is the right operation for this patient, but it's only the right operation for this patient if you're able to undertake that operation. So we also have to adapt around local skills, local product availability, whether you do have a robot or don't have a robot. Lots of things will come into that equation. So I'm sorry I've waffled on, but not a quick answer.
Yeah, I also think you've answered something slightly different than what Laura has asked us. She was asking about the surgeon and medical provider communication to caregivers. In the outcomes, I think it's crucial to communicate with the families of the patients because they know them the best. And I think
that's, yeah,
you have mentioned
that's
the
true. I
care
always
bundles
enjoy
and some.
if the wife or husband of the patient or the parents
Yeah.
of the adolescent are in the room, that they listen to what's going on as well.
Yeah.
Yeah,
Yeah, yeah, I think
right.
it's
Getting
very
the team on
important,
board.
and also it's important to let them speak and give them some interface, like a app, for example. I think which is ideal. But we have some more questions. Bengt Novik from Sweden has been listening to us, and he's asking about antibiotics, which antibiotics to use for which hernias. I think it's a very difficult question to answer. For groin hernias, never. For umbilical hernias, if you read the guidelines, almost always, and which ones depends on your hospital protocol. For incisional hernias, I think the recommendation has been made the same. And the type very much depends on what your hospital recommends, because most hospitals have their own protocols for antibiotic prophylaxis. There is Pablo asking us if we have any protocol, second victim protocol in our hospitals. So in my hospital where I work, we don't, but I know that you do, Andrew, don't you? You have like a debrief if there's something.
Yeah, we do, but it's not as refined as, say, some centers that have in America, for example, that have formalized it. But we are moving that way. We're starting to realize that these people need help. I had a problem a few years ago, and my wife knew about it before I told her, because they had phoned her. My wife's also a doctor. They'd phoned her to say that I might be coming home slightly distressed, so she was ready for it. And in a sense, they used her as a method to keep an eye on me. Although I did, theatre managers and what have you did discuss how I was feeling a week or two down the line. So we do have systems, but they're not particularly formal yet.
Yeah, I think it's a big shame. My hospital, they tried to make like an anonymous group. You can go and chat to some people, but there's no protocol that would actually identify a surgeon in trouble to start with. And I think that's very important. And there's been, I'm not aware of any surgeon, but I'm aware of many healthcare providers. And even in my hospital, I'm aware of at least 2 in the past decade who've taken their life. And it's not really clear why. So there's a question from Alexandros. He's talking about common bile duct injuries, and you cause a complication, so you don't fix it. You call somebody else to fix it. Do you think it's a good idea to do it in a hernia surgery field as well?
I guess it depends what the complication is, but sometimes you do need to call a friend. I remember having an iliac vein injury after a multiply recurrent inguinal hernia that I was doing open, actually. And I ended up in the iliac vein because there was mesh in the preperitoneal space. There were several meshes in the anterior space. And in getting all this mesh out, I obviously made a little hole in the iliac vein. Now, I probably could have repaired that, but I thought this could be a life-changing injury if I get it wrong. So I called for help. The difficulty would be if you're in an environment where, I suppose with bile duct injuries, if you are an HBB expert and you called for help and the only other person was someone who was a colorectal surgeon, well, maybe that colorectal surgeon isn't the right person to repair the bile duct injury. But calling for senior help, even if it's not in your specialty, allows you to deal with the problem better because you have an experienced pair of hands to retract, to mop any blood or bile out of the way or whatever. So I think calling for help with someone who can help you and even just someone who can talk through some of your ideas as to how you're going to fix it is a very valuable tool rather than just soldiering on by yourself.
Definitely. And I think one thing related to it is what happens after the operation and speaking to the patient. And we have one lady who collaborates with us, and she is a patient herself. And she stresses this out a lot, how when she was suffering from her complication, how the surgeon's approach coming to her and explaining what went wrong and talking her through the whole process was very helpful and actually healing for her and healing for her anger as well and for the misery she felt. So I think call for help, definitely. Call for somebody senior to come and be with you in the theater, but don't run away from the situation and never run away from the patient that you have done something that you didn't plan to, because they will appreciate your honesty. And you may also feel a bit better if you don't run away, I think. Is
It is
Johanna
hard speaking to
Ostenberg.
patients. I find it very difficult to go and speak to a patient where you have perpetrated something. In hernia surgery, you've cut the vas or injured the testicular artery. Well recognized, 1 in 1,000 risk. It is difficult. It's probably helpful. You laugh at some of our checklists, but our last one at the end of the operation, did anything happen that the duty of candor, which is the speaking openly, has been breached? So in other words, is there something that happened that we need to tell the patient? That might have been a drug reaction. It could have been a surgical misadventure. But as soon as that's logged, then there's a follow-up process to make sure that whatever it was discussed with the patient. And some of it is important. If you have a first anesthetic and you have a difficult airway, well, that's a duty of candor. It wasn't an error, but it's discussing with the patient, you have a difficult airway. Next time you have a general anesthetic, you need to warn the anesthetist. So sometimes it's not necessarily a mistake. It's harder when there's been an error, interruptive error. That's much harder to chat to the patients. But most patients will be grateful for the knowledge and for your honesty.
Yeah. Johanna Ostenberg has a comment here. She is saying probably she does it in her institution, the black box concept where everything is recorded. And it's very, very useful to be able to go back to in the aftermath. If there is a problem, to be able to see your own mistakes. I think everybody is very knows Knut Borg. He is the master of teaching, and he does use all these videos to educate others on when the mistake was wrong, when things went wrong. And these videos are definitely very useful. I don't think all of us still have the ability to have those. Not all the ORs are equipped.
Complicated. Obviously, you can collect your own videos, although we're supposed to tell patients they're collected. They should be part of the record because the patients can ask for records to be destroyed. If they sit on a hospital server with a record because of the number of operations done, that's a huge amount of video. And the electricity to run all those servers is a massive pollution to the world. So there are positives and negatives. There's no doubt if there's a bile duct injury, reviewing the operation up to that point. And I suppose with some laparoscopic hernias, there are early failures, and that's usually due to technical errors. So you can go back and look at the video. If there's bowel injuries, again, go back and look at the video and see where did it happen. So they are very useful for learning, but administratively, they're expensive if they're done properly and made part of the patient's record.
Yes, Johanna says they have them for 6 months.
Yeah.
I think it's very sensible.
Yeah.
I think we have
tried to
come
use
to
that
the
in our
end.
hospital, and it was turned down purely on cost, even though there are a lot of benefits to that.
I think we have ran to the end of the session.
I think we have
10 minutes too long.
I hope I've not depressed too many people. I hope I've encouraged them more to be hernia surgeons, use Hernia Basecamp, join the EHS, travel the world. I know that's bad for the environment too, but you can do it on a bike or train. And we shouldn't forget to tell everyone that the European Hernia Society meeting is in Prague next year with Dr. East, our Congress President, the 29th to the 31st of May, 2024. See you all in Prague.
Very difficult to bike to Edinburgh, just so you know. I hope to see you all in Prague.
Well, thanks everyone for listening. Thanks, Barb, for interrogating me yet again. I'll surely get my own back on you one day.
Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars, and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters, and the world's leading experts, with certification on completion. You can attend lectures, view videos, or look up information, keeping you up to date with the latest views and technology via a user-friendly interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today.